Hello everyone, this is Dr. Mahesh Malu from the coastal town of Andhra Pradesh, Visakhapatnam, presenting the paper on the topic The Pancreatic Puzzle, Radiologist's Role in Unmasking the Common and the Rare Phases of Pancreatitis Complications. Acute pancreatitis is defined as inflammation of the pancreatic parenchyma, which is characterized by the presence of edema, acute inflammatory infiltrates, varying degree of cellular apoptosis, necrosis, and the hemorrhage. Acute pancreatitis is one of the most common gastrointestinal cause of death, with the mortality around 5%, while 47% in patients with multiple organ failure. The aims and objective of my study, the paper, is evaluating the complications much beyond the Balthazar severity grading and the modified CT severity index. Understand the role of imaging, especially the contrast enhanced CT, in diagnosing acute pancreatitis and its complications. Retrospectively, involving 120 patients with the raised biochemical markers and the clinical presenting with the clinical symptoms. The duration of the study was over a period of 10 months, the last 10 months. Underwent contrast enhanced CT with the 128 slice Siemens, which followed a standardized protocol of the acute pancreatitis that is involving late bar delayed arterial and the portal venous phase. In the inclusion criteria, which was used for the study, was the age of the patient more than 18 years, and the second was clinically diagnosed cases of the acute pancreatitis, and the features such as presence of abdominal pain, threefold increase in the biochemical markers, amylase and the lipase, and the third is the presence of the radiological findings. The exclusion criteria which were applied was the coexisting malignancy, hypercoagulable state, and the hypersensitivity to the iodinated contrast. The results are categorized into the 5 subcategories based on the complications. The first is the inflammatory complications such as pericholecystic fat standing, cholecystitis, cholangitis, duodenitis, and the AKI. While the vascular complications, portal vein thrombosis, splenic vein thrombosis, thrombosis involving the splenoportal confluence, left-sided portal hypertension. The complication based on the collections, acute fluid collection, pseudocyst, and the necrotic collections. While the systemic complications involved systemic inflammatory response syndrome, respiratory failure, ARDS, pleural effusion, atelectasis, renal failure, cardiovascular shock, and the CDA. While the most important, the pancreatic puzzles, the unusual, the unexpected sequel, which we got in the study were such like pancreatico-cutaneous fistula, pancreatico-pseudoatrophy, flank atrophy, bowel obstruction, pancreatico-pseudocyst renal connection. So these were the cases which were much beyond the criteria which we usually follow. The statistical analysis of the incidents. Out of the 120 patients, 73 were male, 47 were female, while the maximum cases were in the age group of 30 to 50, while the minimum were in the above 70 years. The analysis regarding the etiology, the most common cause for this was the alcohol, followed by the gallstone, followed by the idiopathic, and the other reasons were hypertriglyceridemia, ERCP, autoimmune, medication induced. Now, the statistical analysis of the complication and the subcategories which we just discussed. The maximum cases were seen of the inflammatory, followed by the collection-based complication, followed by vascular, followed by systemic, and followed by the pancreatic puzzles. And there can be combination. There were cases where we can see inflammatory as well as vascular, and the combination of any of these subcategories. So let's start with the pancreatic puzzles, the unexpected, unusual complications which we got in this study. As on the right, you can see a CECT axial image taken in the late arterial phase depicting the multiple air foci involving the body and the tail of pancreas. It is an emphysematous necrotizing classical case. While on the left, you can see CECT coronal late arterial phase image showing the dilated bowel loops, showing the dilated large bowel loops and the abrupt narrowing at the level of the proximal descending colon adjacent to the tail of pancreas. The dilated large bowel loops and the distal small bowel loops. This is presenting a case of bowel obstruction. So this is a case of acute pancreatitis, but the presenting symptoms features all were of the bowel obstruction because secondary to the inflammatory stricture. Now let's discuss one more interesting case that is depicting the asymmetry of the anterior abdominal wall muscles. Thinning of the internal oblique muscle is seen on the right side. The enzymes from the inflamed pancreas or the pancreatic pseudocyst may irritate the transversalis fasciae and the muscles in the flank region. So this results in the fat atrophy. As you can see on the right side, there is a muscle thinning involving the right internal oblique. That is, this is a case of flank atrophy, a case follow-up of the acute pancreatitis complications. The third is the one interesting case on the MRCP. It was diagnosed as a pancreatico-cutaneous fistula, a fistula communicating between the main pancreatic duct to the skin surface in the left lumbar region. As in the image on the right side, you can see the cutaneous fistulous opening, while on the left side, you can see a pancreatico-cutaneous fistulogram and the C-arm guidance depicting its path. Now, let's discuss the next subcategory, that is the inflammatory-based complications. This includes the maximum case of the duodenitis, followed by cholecystitis, followed by cholangitis, AKI. A representative case here, a coronal CECT, portal phase depicting extensive pericholecystic fat stranding, cholangitis, duodenitis, and the fat stranding surrounding the distal portion of the ascending colon, as you can see in this image. Now let's discuss the vascular complications which we got in the study. The most common were the portal vein thrombosis, followed by splenic vein thrombosis, followed by the left side portal hypertension, and a single case of pseudoaneurysm rupture. CT coronal showing a filling defect at the level of splenoportal confluence and the portal phase, the most commonly seen vascular complication followed the acute pancreatitis. The third category was a systemic based complication. Most commonly we see is the ARDS, pleural effusion, atelectasis changes, while the other are renal failure, hemodynamic shock. CECT axis depicting the thickening of gerotas, lateral corneal fascia, a perirenal fat standing, and the clinical symptoms include the decreased urine output with the deranged serum creatinine, features of the early renal failure. The complications of the collection based where let's discuss the criteria, how we segregated first of all. It is a 1992 Atlanta classification, which all of us know. That included the term abscess, but what we follow currently is the 2007 revised Atlanta classification, which divided based on the interstitial idiomatous pancreatitis, necrotic pancreatitis, and the duration of the presenting symptom. If it's less than 4 weeks, it is acute peripancreatic collections, while if it's more, either it is pseudocyst or the walled of necrosis. So the conventional assessment of severity is the Balthazar CT severity index, which primarily deals with the pancreatic inflammation and the pancreatic necrosis. There is no comment about the extrapancreatic involvement. So there was a requirement of the new scoring system, which led to the modified CT severity index of the acute pancreatitis, which is the most commonly followed across all the departments. It involved the pancreatic inflammation, pancreatic necrosis, and the most common extra-pancreatic complication, which involved pleural effusion, ascites, vascular complication, GIT involvement, parenchymal complications. So the severe acute pancreatitis of score of more than 7. Imaging is typically not indicated in the early course of acute pancreatitis because the diagnosis can be made on clinical and the biochemical data. The management of acute pancreatitis is largely influenced by two main factors, severity and the complications. One of the most crucial steps in the initial management of patient presenting with acute pancreatitis is determining the etiology so that any reversible cause can be addressed promptly. Once the etiology has been addressed, the severity can be managed and the triage system can be applied. The management of acute pancreatitis is mostly supportive care. However, the challenge of treatment occurs when the patient presents with the severe disease and the complication. So that where comes the need of this study, the evaluation of the complication, which guides the management. Therefore, a multidisciplinary approach is utilized when there is indication of intervention. And the most important aspect when we are seeing the pancreatic gland is the amount of necrosis, location of the necrosis, because a patient with the presence of necrosis is 10 times more likely to have a surgical intervention. Other modalities and its role. Ultrasound is potentially a valuable tool in the management and the follow-up of the various complications of pancreatitis, facilitating bedside imaging, diagnostic aspiration, and the drainage insertion. While the fat set titubated imaging is useful for characterizing the collection before drainage. So the conclusion of my paper is acute pancreatitis is associated with a wide variety of complications affecting the pancreatic gland, pancreatic duct, surrounding vasculature, and the abdominal organ structure. The role of the radiologist in the imaging of the acute pancreatitis and its complication is to select the most appropriate imaging technique and to diagnose local complications that will guide management decision and reduce the morbidity. The references which I used for this paper and the study are this.